Well, good afternoon, everybody. I'm Bob Vonderheid. I'm director of the Abramson Cancer Center here at the Perelman School of Medicine. I want to welcome everybody and thank you for coming. We are recording this event, but it's not live, so you're behind the curtain. This is the real deal. Thanks for being here in person. This is Breakthrough and Discovery panel for the Vassar Symposium, our 11th symposium, and I'll just make a few opening comments and then introduce our moderator who will introduce the guests for today, okay? Science works in service to others, and that's Vassar Center is emblematic of that mission. And a family's love inspired the creation of the Vassar Center and made the rally call to change the way we think about genes, family, history, and how we can change the world as a community. So I want to thank Mindy and John Gray, the founders of the Vassar Center, as well as Sherry and Len Potter for your leadership and commitment to the Vassar Center and to Penn Medicine and to the University of Pennsylvania as well. And thanks too to the many, wouldn't be here without you and certainly not without all this progress. And to the many members of the Vassar Center Advisory Board who are in attendance, and please accept our deep gratitude for your passion and commitment and your time and your advocacy as well. So let's clap for them too. So inspiring collaboration is a signature part of the Vassar Center, as it is of the Abramson Cancer Center and Penn Medicine as a whole. And we are all part of this great university and committed to our motto, which is knowledge for good. This year's Breakthroughs and Discovery panel is going to focus on the concept of cancer interception, which is a new approach to cancer care, and we're going to go in depth about it with regard to pancreatic cancer screening and treatment. Cancer interception is not the same as prevention. It's not the same as therapy. It's about stopping cancer before it takes hold. As you can imagine, it has tremendous promise to make a difference in the way we approach cancer and those at high risk, especially those who have BRCA1 and 2 mutations. I think of it as cancer is writing its story on a dry erase board, and it started to write, and we're just going to come in and dry erase that off. And then if it starts to write the story again, we're going to erase it again and again and again. Interception is here and now. It's not a fairy tale. In the lab, speaking of pancreatic cancer, we can make the very early lesions, the first mistakes, go away with new KRAS inhibitors. We can change that with vaccines against pancreatic cancer. And that vaccine is now in clinical trials here at Penn, and the first 3 healthy BRCA carriers have been treated. So far, so good. Pretty amazing. Okay, so I'd like to introduce today's moderator, Mr. Dave Price. He's an integral member of the Vassar Center family with an impressive and award-winning career in broadcast journalism spanning almost 3 decades. He's that guy way down there. Dave, Dave is currently weather anchor for NBC4 New York and has spots. You've seen him on The Today Show, MSNBC, NBC News Now, and you might have seen him at the Vassar Gene Bash a few months ago as well. Of course, as many of you know, Dave's toughest assignment and most meaningful assignment was supporting his brother, Steve, our dear friend, during Steve's 4.5-year battle with BRCA-related pancreatic cancer. Sadly, Steve passed away in April of 2021. Being there for his brother and taking joy in the time they had together inspired Dave to live with a new model for living life, one filled with voluntarism and gratitude, and has been an incredible advocate for patients with pancreatic cancer. Dave's passion, fueled by love of family, continues to inspire us, and his service to others inspires us, including here at the Vassar Center, all the while honoring Steve's life and legacy. We are really honored, there's Steve, we are really honored that the entire Vassar Center Annual Scientific Symposium this year, including this session of Breakthroughs and Discoveries panel discussion, are dedicated in Steve's memory. May his memory be a blessing. And with that, please welcome our dear friend, Dave Price.
So, good afternoon, everyone, and you have to both excuse and understand the tears. As I look up at that picture, I am so aware of my brother's presence today. And at the same time, each day I manage through sadness and heartbreak. Everywhere I go, and every place I am, he is along with me. And so today I'm particularly proud to be here with you, with our extended family at Vassar, because Steve and our family were incredible beneficiaries of the science and the care here. And he took great pride not only in his involvement, but in the progress that was being made. And what's remarkable is that Steve knew that with each and every day, there were breakthroughs and research and work which was being done that if it wasn't available to help him, it would someday help others. And that gave him incredible comfort. And today, in his memory, gives me great pride. So I can't tell you how happy I am to be here and to be involved. And I will tell you today, we're all part of the Vassar family. So to all of you and to each one of you, thank you so much in advance for being here this afternoon. And give yourselves a round of applause. I want to get onto the panel, and I just want to begin by using Steve's own words. Every year, he used to write a letter to his caregivers and his doctors, and this one was from 2017. On this day, it is Acinar, and Allison gave me my definitive diagnosis and set off with me on a journey defined equally by science, hope, persistence, and imagination. My ambition at diagnosis was for a few months to share with those I loved, and then a relatively orderly and painless departure to parts unknown. I could never have imagined the magnitude of the adventure ahead of me, nor could I imagine the astonishing people with whom I'd get to share that adventure, much less the extent of our success. And so now, 4 years later, 4 years of life, of thrills, of spills, triumphs, tragedies, happiness and sadness, and all the things that define the human condition. After all those years, I thank you. And I look forward to sharing more with each of you and to experience more of your milestones and mine together. And with a little luck, one of those will be the day when a 4-year survival with stage 4 pancreatic cancer barely merits a candle on a cupcake, because you and others will have succeeded in making this an ordinary miracle. And we are succeeding. How many people here are here for the first time? Fantastic. How many people here are patients? How many people here are caregivers? How many people here are practitioners? Look at that. We're well represented today. And so to patients and caregivers, I tell you this, my brother did not lose his battle with cancer. my brother won his battle for 4.5 years. And my brother won that battle because of the people on this panel, the people at Vassar, the people at Let's Win, where I serve on the board, and because of therapeutics that weren't even available the day he was diagnosed. And the pace of progress becomes more rapid each and every day. So I'm here certainly grieving the loss of my brother, but I want you to know I'm here because I'm on your team now. And together we're going to win. And together we're going to make more progress. And the lives of cancer patients are going to be better and longer until eventually we're just here for a reunion. So I want to welcome our panelists and thank each and every one of you. I sat here for some of your talks, and I think I merit earning a master's at least for getting through that. It's remarkable. Your focus and your dedication is remarkable. So for those of you who are not familiar with our panelists, let me introduce them. To my left, Susan Domchek, who is the executive director of the Vassar Center. And in addition to being the center's incomparable leader, she is a compassionate clinician. And I can tell you that firsthand. She is a dedicated researcher. Her research primarily focuses on the genetics and treatment of individuals with inherited risk factors for cancer, like the BRCA mutation. So it is of primary interest to so many of us in unraveling and unlocking the mysteries of BRCA. Dr. Fergus J is chair of the Division of Experimental Pathology and Laboratory Medicine at the Mayo Clinic. And if you listen to him, he is also the voice double for Liam Neeson. Dr. Couch is the recipient of the 2022 Vassar Global Prize and gave the keynote address at the Vassar Scientific Symposium earlier today, which was just remarkable in the scope of progress in what has been his life's work. And I think even though for lay people it may have been difficult or challenging to understand, I think the net results, which we're going to hear about today, in simplified terms, should give us all reason for hope. And by the way, not simply for unjustified emotional hope, but because of factually driven, foundational, objective progress and hope. The long-term goals of Dr. Couch's work are to develop methods that predict an individual's risk of developing breast and other cancers and facilitate cancer prevention efforts, as well as to develop tests that improve the selection of treatments for individuals with breast or other cancers. Imagine if we can come in and if we can more carefully or specifically define therapeutics for our individual cancers. Think about what that holds. And by the way, not for the future that's forever from now, but for the future that is weeks and months and just a few years ahead. So thank you, Dr. Couch, and welcome. I don't want to miss one here, so forgive me. Dr. Bryson Katona is an assistant professor of medicine right here at Penn Medicine's Abramson Cancer Center. I should mention Dr. Katona was in Chicago first thing this morning and has flown back, and we are so grateful for your effort to get here. He serves as the director of gastrointestinal cancer genetics and director of the gastrointestinal cancer risk evaluation program. And his focus is on the diagnosis, risk assessment, management, and biology of hereditary gastrointestinal cancer predisposition syndromes, including pancreatic cancer. And I kid you not, if any of these terms or titles is a little bit spin-inducing, don't worry about that, because they're going to explain it so that we can understand it. Not only that, so we can use the information that is often so overwhelming. And that's, by the way, the great value of this panel. He's received several awards for his work, including the Vassar Young Leadership Council Young Investigator Award. He's won a Grammy and a Tony. Oh, no, I'm sorry. That's incorrect information. So much for research. Dr. Kim Reiss, who I adore, because Dr. Reiss was one of the people, including Dr. Domchek and Dr. von der Heide, who gave Steve those 4.5 years. And although it may be odd to say as an introduction, let me begin by saying I love you, I adore you, and I am so grateful to your parents for having you. So Dr. Reiss is a clinical and translational researcher who specializes in gastrointestinal malignancies with a focus on therapeutics for patients with genetic predisposition syndromes and pancreatic cancer. She's received numerous research awards for her work, including the Vassar Young Leadership Council, Young Investigator Award, and the Pearl and Philip Vassar Innovation Research Award. She is a genius, and beyond that, she has the heart of an angel, as so many, and in fact, all of the people I've ever run into here have. So, but you're a leader, and I love you for that. So thank you.
Thank you.
So that is our panel. So why don't we get to some questions, and let's do this like we would in a really good college class. And I'm asking you, if there's something you don't understand, or somewhere you want to stop, or something you think you need to get down before the final, okay? Raise your hand, and we'll find a way to work it in. But before we dive into the advancements being made, let's go back. And Susan, can you take us back and briefly explain BRCA1 and 2 gene mutations and their net impact on cancer risk?
So absolutely. And first, I just want to say that your introduction always brings home why what we do is so important. Just every moment, every day, we know that even though we make advancements, as long as if we're leaving one person behind, it's too many. And so we are motivated, every person up here is motivated to do better. I also did hear the advice to keep things in simple terms. That was very subtle, by the way, but I'm going to try really hard to keep this in that way. So BRCA1 and BRCA2 really stand for breast cancer 1 and breast cancer 2. That's the names of the genes, and we're not that sophisticated. And they were called that because initially they were really identified as breast cancer susceptibility genes. And both increase risk of cancers, but in slightly different ways. So both increase the risk of breast cancer with lifetime risks of up to 70%. But the breast cancers are different. BRCA1-related breast cancers are mostly what we call triple-negative breast cancers, not sensitive to hormonal therapy. BRCA2-related breast cancers more likely sensitive to hormonal therapy. Both BRCA1 and BRCA2 increase the risk of ovarian cancer, although more so with BRCA1 than BRCA2. And then they increase the risk of bad prostate cancer and pancreatic cancer, and in this case, more BRCA2 than BRCA1. So we don't really lump, we really split, and we try to individualize those risks. And a lot of what we're going to talk about today is pancreatic cancer, because this is one of those that in the beginning days, we really were so focused on breast and ovarian cancer, but we know that we really do need to pay attention to both pancreatic cancer and prostate cancer.
So we're learning basically from BRCA1 and 2, not only how we can better treat breast cancer, but the application of therapeutics towards several different cancers as well.
Absolutely, and we're going to hear more about this, but in the early days after BRCA1 and 2 were cloned, all we knew is that they were these genes. Nobody even really knew what these proteins did, much less how on earth one would go about targeting them therapeutically. For BRCA1 and BRCA2, when the cancers develop, the cancers lose the protein. So you're born with one bad copy of BRCA1 or 2, and in most cases when the cancer develops, the second copy is lost. Cancers, it's actually easier to target things that are turned on. How you target things that are turned off was actually quite a mystery that was not solved by me. But again, in this idea of collaborative research, many smart people figured out this concept of synthetic lethality, where you could somehow target something that was turned off. And that was developed sort of in ovarian and breast cancer, but is now very relevant to prostate and pancreatic cancer associated with BRCA mutations.
And the rate of progress on all this research continues to advance with CRISPR technology and all that's being developed in parallel paths and concurrently. And as we turn to Dr. Couch for a second, I just want to say this. I remember being in a meeting with Dr. von der Heide early on, and Dr. von der Heide said to my brother, who had, again, advanced stage 4 pancreatic cancer, Steve, your job is to swing to the next vine. Yeah. Just extend your hand, focus on that vine, and swing to it. And our job is to create the vine. And we're going to do that. And we did. And think of all the vines that have created themselves and have been created by researchers since then. It's amazing. So with each and every discovery, there's excitement, and there's greater promise, and there's a greater ability to focus. So let's go back a little while we're on that trip down memory lane, Dr. Couch. You were at Penn in the mid-90s when BRCA2 was being cloned, along with Catherine Nathanson, who was Vassar's director of genetics. Take yourself out of the role of doctor for a moment, and as a human being first, and then as a researcher, what was it like having a front row seat on that discovery, and how has it impacted every one of your moves since?
Yeah, great
in
question.
10 seconds.
No, no, it was an amazing time because everybody was so energized. We had just really discovered that genes could drive cancer. That was sort of a new discovery at the time. And so here we were at the forefront trying to find, at that time, probably the most important genes known to humans in terms of disease. And really just so many people involved, team science, working together, endless hours in the lab just trying to figure this stuff out. So it was just amazingly energizing. And you knew you were helping people. You know, if you could discover this gene, how many thousands of people around the world would benefit? That was the main driver. And so I do this today. And even today with my students who, you know, they're a little bit divorced from all of that. They don't really see it. But I try to engender that concept to them, is that we're doing this for the patients. We're not just doing esoteric science. We're not just trying to publish the next manuscript. It's all about the patients and making discoveries for their benefits. So it has kind of changed my way of doing science, being involved in those early discoveries, and just trying to do translational research and really make a difference. It's influenced also the drive behind the science. You know, when you know you're making these big discoveries and really helping people, you just push that a little bit harder, I think. And so again, I try to get that message across to my students that this is not just your average project. You know, we really have to be driving hard.
It must give you tremendous satisfaction even to look out at an audience like this at night as you put your head on your pillow to say, our team, our family, Vassar, the wider network of researchers are going to make these lives, these people, better and healthier. It must be a remarkable feeling.
It is. I mean, because there's a lot of science that's done where it's just esoteric stuff, or you're in the lab and you're making discoveries for the sake of discovery. But this is different. This is helping people, and it really energizes. And the other part of it is that the work that we've done on breast cancer and pancreatic cancer has really brought so many different researchers together. Science is somewhat famous for being siloed, right? Everybody does their own thing in their own little ivory tower. But this field is different. I think Susan would agree with that. Really, we've really come together as large teams to make a difference. We've all realized that on our own we can't do it. We have to work together. And so there's people all over the world really forming groups, collaborations, working hard together, sharing their data to try and make that difference for the patient.
And we saw evidence of that, for those of you who weren't here earlier for your talk, of what seemed to be 140 people on a Zoom call in the middle of the pandemic around the globe. So rest assured, the work never stops. And if it ends for the day in one time zone, it's being picked up in another. And so it's quite continuous.
Yes.
So thank you so much. Susan, back to you for a second. You know, the Bassler Center was founded 10 years ago. There are never enough ways to say thank you to your entire family, and so we won't stop ever. And it was all started to accelerate research into BRCA-related cancers. So how have the approaches changed over time, and how has genetic testing improved for those who are at high risk for developing BRCA-related cancers? So if you put it in a 10-year time zone or a timeline,
Right.
and we start at zero and we get to here, what have we done, if you will?
Right. Well, there's many different elements, but I think that the two things that probably have moved the needle the most are trying to get more people tested and for more genes. And this is where I think Dr. Couch will comment more on this. BRCA1 and BRCA2 are common, and mutations in these genes have a high risk, but there are other genes. And how we investigated and came to understand BRCA1 and 2 associated risks allowed us to then sort of figure out risks of other genes. And that then subsequently allowed us to kind of understand better who should be tested. The thresholds for genetic testing change over time. That's okay, by the way. Sometimes science is sort of given a hard time because our recommendations, I don't know if anyone saw the mammogram story, but yes, the mammograms recommendations have changed yet again today. And we don't do ourselves a good service when we do that. But changes over time in terms of who should get genetic testing has changed as we understood more. So compared to back in 2012, many more people are eligible for genetic testing. Many more people are getting testing. But we're trying to make it easier and easier. We're trying to make sure that there are no disparities. We're making sure that the people who need the information most get it. So that's one big thing. And the second thing that I think we'll talk more about is therapeutics, which is developing these therapeutics and then taking them earlier and earlier into patients' courses to try to really end up not just improving survival, which is always a goal, but actually curing patients of their disease.
10 years. Think about what we've done in 10 years. Think about what we're going to do in the next 2. That's what should bring about a smile and what should bring about a sparkle in your eye, is because the gas pedal has been floored since day one, and we keep on accelerating. We've not even topped out yet. So thank you. We are sitting with esteemed company, but clearly Dr. Couch is the 10th global prize recipient. You've clearly made instrumental contributions to this field. And you had one of the earliest papers on risk assessment. So let's talk a little bit about advances in research in risk assessment and the identification now of a lot of genes associated with breast and pancreatic cancer risk. Take us through that just a touch.
Yeah, so I mean, these genes were all discovered quite a number of years ago, but they sat there unexplained to some extent. We really didn't know which cancers were associated with mutations in those genes, what the levels of risk were. So as I mentioned in my talk, we were lucky enough to be able to team up with testing companies to get enormous data sets, which is what's required to figure this all out. You just need huge numbers of patients to do these things. And again, this is why normally no single investigator can do this work. But in this case, we had a commercial entity that was willing to collaborate with a scientist. So sort of a public-private partnership in a way, which was unusual at the time. And they provided us with enormous amounts of data that allowed us to figure that out for a lot of the genes for breast cancer. So now we have about 9 or 10 genes that I think we would confidently say are driving breast cancer. And then the same for pancreatic cancer. Once we had started that work on breast, we decided to look around to see if there were large pancreatic cancer sample sets. And actually, at Mayo Clinic, where I work, there was a very large collection from Gloria Peterson, who unfortunately passed away from pancreatic cancer just 3 months ago. So Gloria was a world leader in pancreatic cancer research and genetics of pancreatic cancer, and she had put together this huge collection. But she wasn't a geneticist with her lab, she was more of an epidemiologist. So we were able to work with her, do a very large study, and come up with estimates of which genes are driving pancreatic cancer beyond BRCA1 and 2, so PALB2, ATM, genes like that, and really figure out the risks. And that was the first big study, I think, in pancreatic cancer that really established these are the genes we need to be looking at. This is where we need to focus. So we've just been tremendously lucky to work with these people who are willing to share these huge collections of samples, and that's made all the difference.
Information sharing.
Exactly.
It's the elimination of the blinders on the eyes and the extension of hands to reach out to other institutions and other researchers and doctors. Now, I know you and Dr. Nathanson and Dr. Domchek have all worked with others on the Carriers Consortium.
Right.
Can you talk a little bit about that and put that into user-friendly terms, if you will?
Yeah.
He's watching.
Right,
Yeah.
exactly.
Yeah.
Most of the studies done in breast and ovarian cancer risk had been focused on patients that had a family history. And we realized that, again, as I mentioned in my talk earlier, we realized that there were a large number of breast cancer patients who had mutations, but they would never have been found. Those mutations would never have been found with current genetic testing guidelines. So first of all, we demonstrated that we were indeed missing a lot of the mutation carriers by not testing. And then we decided we need to come up with estimates for the general population. That's the terminology we use. We're talking about all the women out there with breast cancer who don't have a family history, if you want to think of it that way. So we went out there and just approached all these very famous epidemiologists and geneticists around the country who had been working on these huge collections of patients for many years. And they had published hundreds, thousands of papers on these things. And we came to them and said, we really want to do this important genetic study. This is what it's about. And they all said, yep, we're on board. Here you go. And they gave us all their samples. I was shocked. But anyway, they all showed up and gave us all their materials. And we just worked hard for 4 years and made, I think, major discoveries in terms of what are the risks for people who don't have a family history. And I think that's really meaningful in the clinic today.
Gotcha. So again, the answer is collaboration.
Yep.
I mean, we keep on coming back to that same theme. And if you're at an institution like Penn Medicine and specifically the Bassler Center that's modeling that behavior, eventually you're going to draw in others, and that's exactly what's been happening. So thank you very much. A lot of people, we've focused on genetic testing. Let's transition a little bit to early detection. And I go to Dr. Katona for that. Let's talk about the current state of screening for pancreatic cancer. First of all, I think a lot of people don't understand that there is screening for pancreatic cancer. So at what age should we start screening? What are the risks with screening? I drop that in your lap and let you take it away.
All right. I will just dispel the myth that I don't have a Tony Award.
But you do have a Grammy.
But just a Grammy, yeah.
Right, there we go.
But yeah.
Right.
I just want to thank Dr. Domchek and the Baxter Center just for having the opportunity to talk to you all today, because pancreatic cancer is an awful cancer. And it's, in my experience, especially with the BRCA1 and 2 carriers, it becomes one of the top cancers that people worry about, especially, after the ovaries are removed, potentially after the mastectomy is done. It really is one of the higher risk cancers for carriers. And so, I think that most people also don't know that there are screening options out there. And to be honest, I think a lot of providers don't know that there are screening options out there. And so I think that, I think it's a hopeful area. It's an area where we don't have as much data as a lot of other areas of screening, but it's an area where there's certainly hope, and data that we're generating is very, very promising. So when I think about screening, I always think about who to do screening in, when to do screening, and how to do screening. And I can give a kind of a bird's eye overview of those different areas. So when we think about who to do screening in for BRCA1 and 2 carriers, typically or classically it was BRCA1 and 2 carriers who had a family history of pancreatic cancer in either a first-degree relative, so like a parent or a sibling, or a second-degree relative such as an aunt, uncle, or a grandparent. However, there's been some controversy about whether or not using family history should be something that's done when deciding who gets screening and who doesn't get screening. And actually recent guidelines that were published last year, which now kind of contradict other guidelines that are out there, now actually open it up to all individuals with BRCA1 or 2 mutations, regardless of whether or not there's a family history of pancreatic cancer. So, I think that the option for pancreatic cancer screening certainly should be discussed with all BRCA1 and 2 carriers. But I think another big determinant is the age. Because pancreatic cancer, although it's a terrible cancer, we know it's not one that typically hits young people. And so usually we don't consider pancreatic cancer screening until at least age 50, sometimes a little earlier if there's a very early pancreatic cancer in the family. But age 50 is kind of the very earliest that we would consider starting. And I think a lot of individuals probably can start even later than that. And then the third part is how it's done. And typically for pancreatic cancer screening, our goal is to detect a pancreatic cancer early. We know that stage 1 pancreatic cancer, people do very well. But if it's progressed past stage 1, survival is much lower. And so if we can catch these cancers at an early stage, as soon as they develop, we know that patients will do a lot better. So for pancreatic cancer screening, usually we'll do annual imaging of the pancreas with either an MRI of the pancreas or something called an endoscopic ultrasound, which is where a tiny tube is passed, while you're asleep, of course, is passed down the esophagus into the stomach. And the stomach and the pancreas are actually next door neighbors, and so we can directly look at the pancreas through the lining of the stomach. And so usually for individuals, carriers of BRCA1 or 2 mutation who want to do screening, we do one of these imaging tests annually. The other thing that we're incorporating into the screening program is screening for diabetes or development of early diabetes. There's been a lot of data showing that sometimes diabetes can be the very first red flag of a new pancreatic cancer developing. And so that's something that we also follow. Now you asked about risks, and then sorry, I'm going probably over my time here. But in general, pancreatic cancer screening is safe. There are some small risks associated with the procedures. So an endoscopic procedure, you need anesthesia, which always has some small risks. For MRI, there's some thought about repeated contrast administration for the MRI. There may be some very small risks. But then for the patient, the other big risk that I always talk to people about is these screening tests, although we're looking at the pancreas, we're seeing a lot more than the pancreas. And so there's always the chance that we call them incidental findings, or basically a nodule or something is going to be found somewhere else outside the pancreas that then certainly may need further workup or may cause worry or concern.
Can we talk a little bit about blood tests? Take us through that subject. I saw eyebrows raised. I saw reactions on the faces. Let's explore that a little bit.
Yeah. So the screening that we have, we're talking about, an expensive MRI, we're talking about an invasive endoscopic procedure. Having a blood test that we could use for early diagnosis of pancreatic cancer really would be the holy grail. And that's, people have been researching this for years and years and years. There are several tests that are out there on the market. There's one particular test that's focused specifically on pancreatic cancer. It's called the IMRAY PanCan-D. I can't simplify that. That's actually the name. There's also a couple other kind of broader multi-cancer detection tests that are out there as well. But the issue is that blood tests, and especially for pancreatic cancer, in order for you to only use a blood test, it has to be really good. And currently, none of the blood tests kind of meet that threshold. But I think it's exciting that 5 years ago, there were none of these products on the market. And now there's multiple companies that are working to develop these products in collaboration with a lot of academic investigators. So I think that the fact that so many people are working on it, so many companies and academic institutions are contributing, the need is there and the motivation's there. And I think it's only a matter of time before we have a blood test that could hopefully help simplify this process.
And there you have it, just to the point we made at the very beginning. Think about what wasn't there 5 years ago. Think about what exists today. Think about the rapidity of progress, and think about what will be here in months and in just a few years. That's what makes this whole conference remarkable, is that 365 days from now, 12 months from now, we're going to have an entirely new bunch of things to talk about and hopefully use in practice. And that in itself is amazing. Susan, while we talk about what wasn't on the market and what is available now and what is in testing now, let's talk about advances in treating BRCA-related cancers over the last decade. Steve was the beneficiary of some of those breakthroughs and some of what was being tested in the midst of his disease.
So one of the big breakthroughs over the last 10 years, actually less than 10 years, is the approval of PARP inhibitors. So this is what I was alluding to when you have to figure out a way to target something that's turned off. This is this concept of synthetic lethality, which I'll try for, which is imagine that you have two pathways that are activated. If you shut down one, everything's fine. You have a redundant pathway, it can work, everything's good. You shut down that one, the other one works, still everything's fine. But if you get rid of both, things fall apart. So one example that people have given is if you take off one leg of a chair, you can sort of balance yourself on three legs. But if you take off two legs of the chair, it's really hard to do that. You're pretty much done for. And this concept allowed for the development of these drugs called PARP inhibitors, initially really focused on BRCA-related ovarian and breast cancer, where they showed pretty dramatic results. And so they quickly moved into not only BRCA-related ovarian cancer, but actually other forms of ovarian cancer that had sort of similar properties to BRCA-related ovarian cancer. They moved into metastatic breast cancer, advanced breast cancer, where it's now really a standard of care. And there's multiple of these drugs that are available. And then they moved into pancreatic and prostate cancer. And Kim will tell you more about pancreatic cancer, I'm sure. But these drugs are very helpful. Some patients derive very long-term benefit from them, but most don't. For most, they stop working at some point. So actually a big focus of our conference was also on why do these drugs stop working and how can we make them work better and for longer, and what can we do after they stop working. But also whether or not taking them into the earlier phases will make them work better, because giving them to somebody who's had advanced cancer for a long time and has received a lot of different therapies, they're less likely to work than if you give them earlier in the process.
So I think you answered what I was going to ask as the follow-up, which is, where are we going from here?
Well, just to give a specific example on that, in breast cancer, we treated, initially they were approved for metastatic breast cancer, people with breast cancer outside the breast, both men and women, by the way, with BRCA1 and 2 mutations. But a large study that I was, again, fortunate enough to be involved in, large collaborative study, 1,800 BRCA1 and 2 mutation carriers with early stage breast cancer throughout the world. This was an incredibly complex trial that really was international. And individuals received all of their regular treatment and then randomly were assigned to get a PARP inhibitor, one of these drugs, versus a placebo for a year. Not only have we shown that there's a decrease in cancer coming back outside the breast, but there's a survival benefit at 3 years, which is quite remarkable. So this is a game changer. It is approved by the FDA for this purpose. So now another reason to make sure, particularly triple negative breast cancer patients get tested, but also high risk ER positive breast cancer patients get tested is, should we give you a PARP inhibitor to improve your survival? So that's where it's going.
And another reason to remain educated and to be your own advocate, regardless of the institution you're being treated at, regardless of where they are in research and development, regardless of what portion of the country you're in. It's a tremendous advantage to be aware as much as you can of what's going on and to ask the question, could this be something we should explore? And any doctor worth their degree is going to have an honest conversation with you about that, or consult a resource who can. It's so important for all of you who are patients right now and caregivers. And we were, I was blessed to have a brother who could have had a medical degree by the midway point in his fight against pancreatic cancer, and doctors who were appreciative of that participation.
And not to interrupt, but I want to absolutely emphasize the fact, if your doctor gives you a hard time about getting a second opinion, you should get a new doctor.
Find a new doctor.
Because no doctor who knows what they're doing has any problem with that whatsoever. When my patients want a second opinion, I'm like, of course you should get a second opinion. I would get a second opinion. So just be sure to know that. Sometimes people are hesitant. Don't ever be hesitant.
Right. This is not dating. Okay, just, we're not sliding to the left. I mean, we are going and trying to find a community of people who can give us or get to the best answer. Dr. Reiss.
Yes, sir.
Let's talk about the progress which we have made in treating pancreatic cancer. We are light years from where we were 5 years ago. We are outside and in a different universe from where we were 10 years ago. And as I throw that question to you, I throw out one more quote from my brother Steve. And he used to say, statistics are certainly valuable, but often they say more about yesterday than they do about tomorrow. And his primary doctor in New York, Dr. Allison Ocean, used to say to him, I don't want you focusing on historical statistics. The only statistic that matters is you. So with that, tell us the hope and the promise and the progress as we have continued to try and cure this
wretched disease.
Yeah.
Yeah, so let me first say that the progress that we've made is never enough, right? So I always start with that because if it's not forever, it's not enough as far as I'm concerned for each patient. But in terms of BRCA-related pancreas cancer, the needle has moved incredibly far in a very, very short time. And we are, as one of the speakers said today, who treats prostate cancer, Bruce Montgomery, we are very far behind the breast and ovarian cancer. So we're just kind of like peeking over the edge and just saying, like, they did that, let's try that. And so far we've been very fortunate to have some success. So for the advanced patients, right? So patients, there are progress in advanced patients. There's progress in patients who haven't been diagnosed yet, which Bryson was talking about in terms of trying to find these cancers earlier. And then there is progress in patients who have been diagnosed but are hopefully curable. So there are advancements in every single space in a short period of time, which I think is so encouraging for us as scientists and also for the patients we're fortunate enough to get to take care of. So in the advanced setting, similar to what has been done, again, you'll hear the theme here, what was done first in breast and ovarian cancer and then moved towards prostate and pancreatic cancer, is that these drugs, these oral pills called PARP inhibitors, started to be introduced into clinical trials for patients with BRCA-related pancreatic cancer. And you have to understand, for metastatic pancreas cancer, for the majority of patients, if you look in the guidelines of what you're supposed to do as the doctor for this patient, it says chemo. And that's all it said. This is up to 3 years ago. It just said chemo, and then you turn the page and there's nothing else on the next page. And so we were treating patients as we did decades ago, years ago in other diseases, forever with perpetual chemotherapy, which for those of you who have had it, and those of you who have taken care of somebody who's had it, know how hard that is and what a life sentence to give somebody that they have to be on these drugs for the rest of their lives. And so PARP inhibitors, which certainly have their toxicity, compared to the chemotherapies that we are having to use to treat patients with pancreas cancer, are so much better. They're not perfect, but they're better. And so being able to, one of the big advancements, it was a huge, again, collaborative study being kind of the name of the game here, huge international phase 3 study of hundreds of patients with metastatic pancreas cancer and BRCA who were taken off their chemotherapy and given a PARP inhibitor, a pill to take to see how that would do. That study showed that it improved the time that they were away from chemotherapy compared to just taking a chemo break and doing nothing. It's not enough because it doesn't change the survival of those patients as of yet. And it also, as Susan mentioned, there is eventual resistance development. And so the next step in our plan is how do we manage that? Okay, but it was a step forward. And that then broke open the door to say, you know what, these drugs have activity. Again, just like in breast cancer, in the metastatic setting, what if we move them earlier? And so born at Penn, there's now a national and again, soon to be international trial because that's what you need. You need numbers. Fergus said it, you need numbers. You need enough people to show that there's a real effect so that these can then get approved and get into the hands of patients who need them. There's now a study going on that is moving those drugs into what we call the curative intent space, meaning you had your surgery, you had your chemotherapy, and if you're up for it, instead of going into screening and just kind of monitoring, you have the opportunity to get randomized into either one of these arms, just like they did in the breast cancer study that Susan described. For every 2 patients that get the PARP inhibitor, 1 will get a placebo, and the doctor and the patient don't know who's getting what. But the point, again, is to try now to move these drugs into patients where we could potentially improve their cure rate. That's the goal. Can we get more people that will then go and live a normal life that will not see this disease again? So we are, I think the progress is, and Steve was part of that progress. Steve was part of that and participated in that progress. And we're so blessed and so fortunate when a person partners with you that way, when a person partners with their physician that way, and you do this together and you walk that journey together, whether it's experimental therapy or standard therapy, the willingness to sort of take the plunge together. So a lot of progress, but a lot more to be made.
Susan, we talked a lot about, the work that Vassar is doing now, and proactivity is a feature of Vassar's next phase. This concept of interception. So can you explain what that practically means?
Yes, so you've heard Bob's explanation of interception, but I will give you a slightly different one. But as we've heard, you're born with one bad copy. Generally, the second copy is lost. Cancer forms. We want to intercepted those very earliest lesions before anyone could tell you you had a cancer. So one analogy is the whiteboard, and you wipe it off. I think that's a really good analogy. Another one is you weed the garden. You periodically take out the weeds so they don't grow, right? And then every once in a while you have to do it again. But the idea is the same, which is you take care of those lesions before they ever become a problem. And you might have to do it, we don't know exactly what it will be, but I will tell you, yes, we do have a vaccine trial. We vaccinated BRCA1 carriers who'd had prior cancers. We vaccinated our first 3 healthy BRCA carriers with an experimental vaccine.
Amazing.
But to get back to your question about clinical trials, these are healthy individuals who are volunteering for a study that they hope will help someone, maybe them, but really almost every one of them so far is doing it for their families, and we have a wait list. And so it's really hard to convey how much of this is a partnership and how much there has to be this mutual trust, and that you trust us so much means the world, and we will do everything in our power to keep your trust and to do everything we can to make a difference.
So Susan, as we wrap, tell us, what makes you hopeful about the future of BRCA mutation carriers?
And again, I do get a little emotional with this, but you've heard about this collaboration over and over again. But truly, I have known Fergus for like my entire professional life. I have had like dinners in Barcelona and in Tel Aviv and in Lund, Sweden with my collaborators from across the world. And it is that level of collaboration and commitment with our advocates, with our patients, that's going to make the difference and move the needle, because we do really all have to do it together. But I really think, given what we've done in like the past 10 years, we are going to make a big difference in the next 10.
Think about that. So, in closing, first of all, I want to thank everyone at the Vassar Center for the honor of having this in my brother's memory. It means the world to me and the world to my family, not simply commemorating his life, but doing something which highlights the promise of this battle and gives people who are exiting this room a reason for great hope and great promise. I know Steve took tremendous pride in supporting those who are fighting by his side. And so I'd ask you a couple of things, and that is, for all of you medical providers in the audience, remember that human. Remember why we're doing all this work. And remember, every single patient is different that you're seeing. And take great pride in the work you're doing and its effect on people. To caregivers, you continue extending your hand and you don't let go of that grip. And to patients, look towards the sun. Tomorrow is going to be a brighter day. And in front of you are just 4 of the people who are going to ensure that. They know this great responsibility, and they've dedicated their lives to helping all of us. Steve was a walking, talking, laughing, loving piece of evidence of what can come of research and care. And I only hope that we continue to build on what we learned with him and from him. And it benefits each and every person in this room today. So thank you, thank you, thank you. It's been a great honor to be here and a great privilege to be a member of the Basser family and yours as well.
Dave, thank you. My job, I'm John Epstein. I'm the Chief Scientific Officer here. They've set me up to let these good people get some dinner tonight. But it's our honor to have been able to hold this symposium in Steve's name, and you've underscored it so beautifully tonight. I want to personally and from the institution thank you for doing such a magnificent job this evening. Susan, you continue to be a master at leading us. Thank you for that. Fergus, congratulations, and your talk was fantastic. Kim, Bryson, thank you for being on the panel. Mindy and John, Sherry and Len, thank you as always for inspiring us, for empowering us. Your personal engagement continues to drive us. You passionately told us today the driving forces that have led to all the advances we've heard about. It makes your family history our family history. It makes your call to action our inspiration. Finally, just a couple of quick observations. I think what we've heard all day and tonight is that all aspects of this mission are personal. Not just the doctor and the patient or the brother and the sister, but even the researcher passionately seeking the tools that are needed. It's personal. And successes are personal successes, but they're global in impact. My own observations over time that scientific advances are not linear. They're not predictable. They happen in little increments at unexpected times and often from unexpected corners. And so I urge all of us to keep an open mind about where the next advances may come from and a broad portfolio of possibilities like a good investor would, balancing the portfolio. Because I don't think 30 years ago, 20 years ago, maybe even 15 years ago, we would have guessed the advances that came from understanding how a T-cell receptor engages its target. And now, we've cured cancers with those approaches. Who knows where the next great insight will come from? So we have to play the long game. These advances take 20 or 30 years often to come to fruition while we create the next vine to swing for. We have to do both at once if we're going to be ultimately successful. I was inspired today. I think that we are making advances. It won't happen all at once. It'll happen little by little. We'll pick off one solution after another until finally we've changed people's lives dramatically and significantly. Let's get back to work after dinner. Thank you all so much.